Whale this weekend.
Yeah.
Yeah, the TV stations are all touting how that's going to be clear and great snow conditions and all the runs are covered. Oh yeah.
We're coming into the 2 hardest weeks of the year for locals.
Yeah.
Yes.
Yep. And for the ER, I would imagine.
Oh, we're happy for the business. I get patients that come in and they apologize. I'm so sorry I broke my wrist. And I tell them my babies are in college. I need you coming in that way.
Yeah.
Yep.
Yeah. Well, I want to welcome all of you to open session of the Board of Directors.
I'm here, by the way, Alice, even though you can't see me.
Okay, I see your name though. Thank you, Bob. General Counsel, please read us out of closed session.
Certainly. The board considered 6 items in closed session. The first was a conference with the Bureau of Property negotiator. There was no reportable action. Second was a liability claim for alleged negligence. That claim was denied by the board on a 5-0 vote. Third was conference with the labor negotiator regarding the EA and EAP. There was no reportable action. Fourth, conference with labor negotiator regarding the president and CEO. Again, no reportable action. Fifth was approval of closed session minutes from the regular meeting on November 18th. Those minutes were approved on a 5-0 vote. And last was medical staff credentialing under Health and Safety Code 32155. And those recommended credentialing decisions were also approved on a 5-0 vote.
Thank you for that. And are there any deletions, corrections to the posted agenda? Seeing no hands, hearing no voices. Martina, did you get any written changes?
I received no written public comment.
Okay. So we go on to item 10, which is the audience input. And again, this is an opportunity for anybody in our audience to make a presentation to the board of 3 minutes of anything that's not on the agenda. And if your time of 3 minutes is up before your presentation is over, I do apologize ahead of time that I'll give you the sign to wrap it up. And also know that the board cannot discuss any items that you bring up, and they can be forwarded to the board. And if they feel that it's something that's warranting discussion, then it can be agendized for the next meeting or so. So do I have any audience input at this time? Now that I've scared you. And Martina, you said no audience input either that you've gotten.
Correct.
Okay. So then I'll close audience input and then I'll move on to input from our Employees Association. Do I have anybody from the Employees Association in our audience? Okay. Any written input from the Employees Association, Martina?
We did not receive anything written from them either.
Okay, thank you. Then we'll close Employee Association input and move on to 12, which is our acknowledgements. And our Chief Human Resource Officer, Alex McLennan, will give us our Employee of the Year and our Employee of the Month.
Chair, I don't see him on yet.
He
Oh,
was stuck in traffic trying to get home. Oh, wait, here he is. Hold on.
okay.
Perfect.
Okay, Alex.
Sorry, I literally just walked in the door, so I appreciate the patience. So I am honored tonight to announce Joji Huarto as a dietary aide in our dietary department as our December Employee of the Month. Joji's been with the organization since November 2017, and here are some things that his colleagues say about him. Joji is an amazing team member. He is always going above and beyond. He's willing to flex his schedule to cover the department. He is cross-trained in both cook and aide positions. He works hard and always has a smile and a joke. He represents the value of teamwork. Another person said, Joji is one of the most selfless, hardworking, and helpful teammates I have ever worked with. He is willing and more than able to help out in any position in the operation. He comes to work with a great attitude every day. No task is below him. He approaches every project with a desire to do his best work. So give it up for Joji.
Hey,
Well deserved. I don't know if
Congratulations, Joji. And if anybody sees him, please tell him that we send our best.
All right.
And then Alex, you have another announcement.
I do. We were able to, on Saturday night at our holiday party, announce our Employee of the Year. And this year, the Employee of the Year goes to a staff nurse in the ER at the Incline Village Community Hospital. And we're honored to announce that is Sarah Wojcik.
Wow, congratulations.
I'll go ahead and read a few things that people have said about her. Sarah's been with the organization since February 24th of 2020. Sarah's incredible, intelligent, and represents the future of healthcare. She brings to the table a level of excellence and competence that is rare. Sarah demonstrates our system's values and goes above and beyond in customer service. She has gone above and beyond, putting in long hours and always being there to help all of us. So again, congratulations to Sarah Wojcik.
Yes, absolutely. Employee of the Year. So Jan, if you're over at Incline, please send our regards to her and her congratulations on her honor.
Yes, I will.
Thank you. Our next item is the Medical Staff Executive Committee's meeting agenda, consent agenda, and Dr. Lane, do you want to present the policies with Dorothy?
I do. Dorothy, why don't you take over the screen if you can and put up there our two policies we're going to go over. So the two policies we approved is use of communication network. And this is, the reason for this is ineffective communication creates medical errors. So this was a lengthy document on proper computer use, email, checking it regularly, allowing access to emails from home, secure chat, my chart. So it really lays out how we can try to minimize our communication problems and how we are allowing everyone to communicate and under what circumstances. Very little controversy in this one. There was no controversy in this one.
Yeah.
And then Dorothy, do you want to go to the next one on Sentinel and adverse events? So this one, so Sentinel events is something that occurs for the first time. We want to make sure it doesn't occur again. Adverse events, errors, or unanticipated outcomes. And this one standardizes the process to identify and review and investigate these type of events. It discusses doing root cause analysis to identify factors that have made or produce this undesired result, clinical case reviews, critical incident reviews, and then it gets very into detail on which events and where they get reported to, both for California and Nevada. So this is a way for us to standardize when something doesn't go right, how do we investigate it? And I think obviously more important is how do we not repeat it? And those are the only two we had.
Dr. Lane, it said those policies were made with changes. What changes were made? I mean, they've been in existence for many years now.
I don't know all of them.
I can speak to that, Jonathan, Dr.
Okay.
Lane. This is Janet. The MyChart policy, we revised the section on responding to our patients. We clarified that process. It's been challenging for our providers to be able to respond as quickly as the patients may like. They really do a great job responding. And so we updated that section so it reflected our practice, since we are in the process of hiring nurses and we use medical assistants to help the physicians respond very rapidly to those messages. The Sentinel event policy is a risk policy, and Teresa Crow, our risk manager, she identified that the California state reporting requirements changed ever so slightly. So she updated that section to make sure the wording reflected the new state reporting requirements. Thank you, Dr. Lane, unless there's a question.
Thanks, Janet.
And could I also ask a question about the risk statements that are added to the policies? Which policies get that? I noticed you had mentioned it at our last meeting, and then I noticed on both of these, they have risks. Do all policies get a risk statement?
That is that's part of the reliability management team, and that is the intent. But as you know, we have many policies. So as we start to go through the various departments and revise policies, we gave the manager directors time to do that over the next phase of approval. So you'll start to see a risk statement over the next 6 months.
Okay, and that's part of high reliability, correct?
Correct.
Is it?
Yeah.
Okay. Thank you for that input.
You're welcome.
Any other questions about the medical executive consent agenda? Anything from our audience? Okay, hearing none, can I have a motion to accept the executive committee, the medical executive committee meeting consent agenda as presented?
So moved.
Can I have a second, please?
I'll second, Michael.
So it's been moved by Director Brown, seconded by Director McGarry, that we accept it as presented. A roll call vote, Martina?
Director Barnett,
Yes.
Director McGeary,
Yes.
Director Shamblin,
Excuse me, yes.
Director Brown,
Yes.
Director Wong.
Yes. So Dr. Lane, it's been approved as you presented it. So thank you so much for doing that. Item 14 is the consent calendar, and these generally are non-controversial reports, minutes, policies, and can be pulled by any member of our board if they want further discussion, or any staff member can pull a item off of the consent agenda. So anything from our board that you wish to pull? Any of our staff members have an interest in pulling anything? Then can I have a motion to accept the consent calendar as presented?
I'll move to approve.
Can I have a second to the motion?
This is Bob, second.
Okay, so it's been moved by Director McGarry, second by Director Barnett, that we accept the consent calendar as presented. Martina, roll call vote.
Director Barnett,
Yes.
Director McGeary,
Yes.
Director Shamblin,
Yes.
Director Brown,
Yes.
Director Wong.
Yes. And then Martina, I'll be in tomorrow to sign that approval of the resolution for continued remote teleconferencing.
Great, thank you.
Item 15, we're going to have Dr. Kame give us the 2021 Cancer Center Quality Report. So Dr. Kame, if you'll go ahead and take over the screen.
The host has disabled participant screen sharing. So Martina, can you give me that capability?
Yeah, you're listed as the co-host, so you should be all set.
Okay. Well, good evening, everyone. Thank you, Chair Alice Wong, and directors and other members of the board. Can you see my screen with my opening slide?
Yes.
Yes.
Great. All right. Well, thank you everyone for letting me speak to this. I'm presenting this with my cohort, Kelly Bottomley, who's the coordinator of our quality improvement outcomes. And this will just take a few minutes. I'd just like to show the number of new cancer patients to the medical oncology side of the house from the initiation of our program in 2006 to 2021. We had a slight decrease from February to April of 2020 related to COVID, but quickly picked up from there. These are the personnel who have joined the program since its first inception with Dr. Larry Heifetz in 2006. There were about 60 new patients in 2006 and over 600 new patients per year now. With growth of the program, we also have growth of our quality program, and you can see that's listed in green underneath, and I'll review some of those in a little more detail here. Also on the radiation side of the house, our program is growing as well. Dr. Katie Lagarza joined the program in FY 2019. Let's talk a little bit about COVID-19, the pandemic, and how it affected us. We did not omit or delay any cancer treatments due to COVID. We were an early adopter of many safety measures to maintain normal operations. We have always done telemedicine with our outlying clinics, and so we were quickly able to ramp that up as needed, including telehealth for clinical psychology and even nursing education. We made careful symptom monitoring of all persons entering the cancer center. Our cancer patients are incredibly vulnerable patients when it comes to infections, and so we took this very seriously. We had a quick pivot to Zoom-based huddles and interdisciplinary meetings, as I'm sure everybody has. Our infusion room expanded to work 7 days a week to support the hospital surge plan. We helped coordinate monoclonal antibody treatments for COVID-19 positive patients, and then just an overall positive attitude. Speaking of COVID and research, we took the opportunity to sign on to a couple of research programs looking at COVID. One is a registry among all of our patients here in the community, and the other was with the National Cancer Institute, looking at how COVID may affect our cancer patients. So heavily involved in cancer research there. And as we speak about research in general, these are our number of enrollments by disease site. We have several different clinical trials. Our goal is 4%, and we exceed that goal each and every year. However, we're not happy with it. This year we had a quality improvement project looking at how we could further expand our enrollment in clinical trials.
Dr. King, can you explain the clinical trials for the psychosocial?
Sure. So one of the things we did was partner with Case Western Reserve University that is doing a survey on cancer patients and how they perceive the idea of big data. As you may know, big data helps us study real world care in cancer patients. And so it's just a questionnaire assessing their views on that. Is it threatening? Is it beneficial? And so we've enrolled, as you can see, quite a few people on that clinical trial. It's not an interventional trial, it's just a questionnaire.
Okay, thank you. That's important. And just to let you know that I graduated from Case Western Reserve.
Well, there you go.
Yeah.
All right, so let's talk about what we participate in terms of accreditations and affiliations. All of you know we're affiliated with UC Davis, but beyond that, we have several different accreditations that we do independently of UC Davis. The most important one is the first one there. That's the American College of Surgeons Commission on Cancer. This has been around for decades, probably 30, 40 years. And it initially focused on surgery, was the appropriate surgery being done on cancer patients, but it's kind of expanded to beyond surgery. This is a very important one that pulls data from the registrar, the cancer registrar. And so the cancer registrar is an independent body of people who collect data and submit it to what we'll call the COC. We'll use that term quite a few times here tonight, the COC, Commission on Cancer. So you can't game the system because it's sent in by independent reviewers. We've been accredited since 2011, fully reaccredited each and every 3 years thereabouts. We'll get reaccredited again this coming year. The next one is an American Society of Clinical Oncology. That's ASCO. ASCO is kind of like, for oncologists, is kind of like the AMA is for all physicians. ASCO is our main governing body that sets out quality metrics. And their program is called COPI, Quality Oncology Practice Initiative. We have been participating since 2017 with reaccreditation in 2020. We'll come up on that again in 2023. We are also part of our radiation oncology program is ASTRO accredited, first in 2017, then again spring of this year. And then we also participate in the Adario Lung Cancer Foundation Center of Excellence since 2017. We also have implemented what's called a CancerLink data system. That's a working with ASCO that is, they kind of do a sweep of our electronic medical record to assess what we're doing. So again, instead of plugging in numbers and data by pencil, it's all done electronically for us. And so that's a very forward-thinking kind of endeavor. And then the last one there is the National Accreditation Program for Breast Cancers. That's NAPBC. We'll be applying for that. We are applying and the accreditation is pending. Now, what this does is all these outside accreditation entities impose standards on us that we then strive to meet. And it helps shape the quality program for the cancer center. It requires we be compliant with certain standards and then compares us against national standards. We also, as a cancer center, can define our own quality program goals. And we do a lot of those. And I'll tell you about a few of those that we've been doing here tonight. So it's both national ones that are chosen for us and ones that we get to choose ourselves. In the COC, these quality elements are nationally standardized by the Commission on Cancer, the NQF, National Quality Forum, and the CMS. And so this measures our performance as a hospital, not just a cancer center, but our entire Tahoe Forest Hospital District. And then we, in the Cancer Committee, we annually assess all of these measures and monitor the outcomes. Let's see. So the Commission on Cancer, the COC, these are 20 of their measures for particular diseases. So you can see there's 20 different measures that we have to meet in each of these cancers. And tonight I will go over the breast cancer outcomes. Breast cancer is our most common cancer we treat here in the Cancer Center. Now, when the COC collects data, there's always a lag time. So they are reporting back to us our performance from 2018, and it gets reported in 2021. So this is the data, the latest data I can report to you is from 2018. And you can see that our performance there is really quite good. We are better than the state of California and national COC programs. So hard to improve on that.
And one thing I want to say about that, because the doctors always just go right over this, but those kind of outcomes don't happen in every program. I've looked at lots of programs outcomes, and this just doesn't happen naturally in most programs. So they do a really great job of following the national guidelines.
Thank you, Kelly. I didn't ask her to say that. Then one of the fun things that we have is we get to look at our program and say, where do we need to shine a light on something? What needs improving? What, and this is organic. I think what makes this cancer program so good is all of us, it's just in our bones that we look around and say, well, we could do this better. Or, just what about this? How do we compare? And so some of the program driven improvements here in the last year has been to look at our stereotactic radio surgery device to better analyze patient imaging and increase accuracy of treatment plans in radiation and oncology. And so that's been done. And then this year, each year we pick a disease and look at a disease, and we ask ourselves, was the diagnosis and evaluation appropriate? Was the first treatment appropriate compared to national standards? For this year, we looked at all patients newly diagnosed or treated with ovarian cancer. We expanded it from 2006 to 2020, and we looked at standards of care for treatment. Also, are we appropriately doing genetic testing on patients with ovarian cancer? The other big study we did this year was geriatric services, and I'll talk to you more about that in just a bit. So in the clinical studies, we initially said, well, let's look in the last 2 years, but we don't have that many patients with ovarian cancer. So we went all the way back to 2006. We identified 29 patients and assessed them for appropriate staging, diagnostic imaging, pathological testing, treatment, referral to palliative care when appropriate, and overall survival. Asking, did the evaluation and workup meet evidence-based guidelines, and the first course treatment meet evidence-based guidelines? And what we found was we looked at all patients from 2006 to 20. As I said, there were 29 patients ranging in age from 34 to 76 years with a median age of about 59, and that's about the national average. Most patients were stage 3, and that's the typical as well. All 26 patients that were resectable did have appropriate surgery. There were about 3 patients, their disease was way too widespread for surgery to be appropriate for them. 25 patients received the appropriate chemotherapy. 3 patients declined any chemotherapy. 1 person did not require a chemotherapy because hers was a stage 1 cancer and didn't require a chemotherapy. We offered genetic testing to 25 women. Remember, some of these women were diagnosed in 2006 before genetic testing became standard in this patient population. Some women declined testing. 2 were referred for testing but lost a follow-up. 7 tested positive for a deleterious mutation, and 14 tested negative for a deleterious mutation. The other thing that's important is when you have a woman with breast cancer is to think about, ovarian cancer, is to think about breast cancer. The same mutations that cause ovarian cancer also cause breast cancer. Those are the BRCA1 and BRCA2 mutations. So in this population, 3 women had already had a previous or concurrent breast cancer. 1 woman had already had a previous prophylactic bilateral mastectomy to reduce her risk of breast cancer. 9 women had breast imaging or referral for risk reduction surgery, that bilateral prophylactic mastectomy. But for some women, the idea of also looking for breast cancer was just not appropriate. Their ovarian cancer was so widespread and their mortality was really quite near. So the idea that, oh, you need to go get a mammogram really wasn't quite appropriate. We looked at the use of a certain drug called a PARP inhibitor. There's 3 different PARP inhibitors that are approved now. FDA approved it in the adjuvant setting, that is after surgery is done and after chemotherapy is done, to use it to try to prevent the cancer from coming back. That was just approved in May of 20 during the time we were collecting all of our patients. 2 women did get a PARP inhibitor in the adjuvant setting to reduce the risk of recurrence. 5 women have had a PARP inhibitor as they've had progressive disease. So using this drug was used appropriately in this patient population. The survival, about half the women have died of their disease. 13 women are still living. 2 women are lost to follow-up. And that's a survival curve there for you that you can see. So we can say that the patients receiving care for ovarian cancer here at our institution received appropriate surgery and chemotherapy. Testing for genetic mutations was appropriate. Use of newer targeted agents was appropriate. What I would say is that when I, as an oncologist, read the record and I can see this woman has widely metastatic disease and therefore we're not getting a mammogram. I understand it, but I think we can do a better job just annotating in the record that we may have had this discussion with a woman, and in shared decision making, we're not going to be getting, a screening mammogram. Now let's talk about geriatric oncology. I got to say, I'm very proud that our cancer center has taken this very complex issue and looked at it very carefully. And that's because cancer, people are living longer, so we are getting older and older cancer patients. I'm giving you some statistics there. 1 in every 6 deaths is from cancer. In 2021, 1.9 million people here in the US will have a new cancer diagnosis, and over 600,000 deaths from cancer here in the US. About half of them of new cases are over age 65. And we are seeing many more patients and treating many more patients in their 80s and 90s. And so a geriatric assessment is a standard baseline evaluation to help identify functional potential toxicity, functional decline, help guide interventions, help develop an appropriate treatment plan, and overall improve overall well-being. So it's a multidisciplinary diagnostic and treatment process that looks at their medical, psychosocial, functional limitations. There's various tools and assessments. I will list some of the ones we've used. And then the idea is to create an individualized intervention plan to detect all those things we just talked about and improve the outcome. So several, I got to say, our nurse practitioner, Jen Simons, did this project for us here this last year. She unfortunately has left the institution. And so until we get another person to fill in her spot, this has come to a certain stage, and it will move forward once we get somebody taking her place. Several tools were used, and I've listed all of them there. All of them take some time, although she states that she could do that in about 15 minutes, do all the assessment tools, but it is 15 minutes. And so that's an important chunk of time in any appointment schedule. We have a great shortage of healthcare providers that specialize in geriatric oncology. And so that's just a void here nationwide. And what she found was that the COVID pandemic further unmasked vulnerabilities unique to this population, including anxiety and depression because of social isolation and fear of infection, as you might imagine. The next thing I'd like to talk about is just some of the nursing team developments. It takes a whole entire village here in the Cancer Center to make this work. Our nurses now work 7 days a week, staffing and supporting inpatient care and series patients. We now can give chemotherapy on Saturday and Sunday when it's appropriate to do so. We certainly assist with the COVID monoclonal antibody therapy administration. We are busting at the seams. In our infusion room, our average daily visits has gone from 18 to 27. That's a 50% increase. And so as soon as a chair is empty, we're filling it again. So each chair is used many times a day. We have, 8 chairs in the infusion area. So you can see we are incredibly busy. We support the COVID vaccine clinic. 100% of our nurses are ONS chemotherapy certified, and 86% of them are also OCN certified, not an easy thing to do. I'll close by saying these are all of the program affiliations and accreditations that we have. You can see the number of institutions here in the United States that have each of these. There's not that many many institutions, I would say, that have all 5 of them like we do. So I think you can be proud of the Cancer Center you have here. Can I take any questions?
The one thing I would also say is that we are the only ASCO approved program in the region. None of the others are ASCO approved.
Well, I must say that we are proud of our cancer center here, and it looks as though you are suffering a little bit from your own success in terms of the infusion chairs and how busy you are and the like. What is in the offing? What is in the future?
So our director and nurse manager are looking at that very, very carefully. Because we're so good at what we do, and I don't mean that to be an arrogant statement, but our nurses are so very good at what they do. We provide infusion services for anybody that needs a transfusion, anybody that needs an antibiotic, anybody that needs a targeted IV kind of therapy. And so we see a fair number of non-cancer patients, patients just needing daily antibiotics. And so we are working with leadership and administration to see, can we offload those patients to free up chairs for our cancer patients?
That's sort of what MedSurg did to you also for the weekends. They used to take your infusion patients, like the antibiotics and things like that. And now you have them back. And because MedSurg has other things that they have to deal with that are more of their clientele.
Right.
And the other thing, Dr. Campbell, that I'm really interested in is the whole gerontological approach to cancer, but in healthcare completely, that we don't really have that many specialists in geriatrics. And I think it's a population that's continuing to grow with a very different focus on health. And whether they're cured or they learn to live with it, or whatever the approach they and their provider come up with. So I think it's an area that I hope will be growing in the future as I enter my senior years.
You and both, Alice.
Melissa Dale here with a question. Do you have a sense of what level of in-migration you're getting for these cancer services?
It's huge. I don't have the exact number. In past years, that number has been over 50%. I will say there is one cancer program in Reno that is overwhelmed themselves, and patients are not happy at times with the services they receive there. So they drive through Reno to come to us. So yes, we have a huge in-migration.
Yeah.
Does any other member of our board have any questions or comments for either Kelly or Dr. Kane?
Bob Barnett here. Just want to compliment the presentation and very proud of the work being done.
Thank you very much.
Bob is one of our new directors, Dr. Kane. Is there anybody in our audience that may have a question or a comment for either Kelly or Dr. Kane?
This is
right.
Jake. I'm very appreciative of all that you do. And the service that I've gotten from your cancer center has been amazing. So I appreciate your diligence and hard work.
And as a board, we appreciate what you've done for Jake as well.
My hair's coming back.
Yeah.
Looking good.
Thank you again, Dr. Kane, for your presentation. And please extend our congratulations on the work well done to your staff as well.
Thank you so much.
So we have some items for board action. One is a resolution 2021, and Crystal Betts, our Chief Financial Officer, is going to talk to us about the bridge loan program for our transition from prime to QUIP, quality incentive program.
Well, geez, Alice, why don't you take it from here? You got this down. So what's before you today is a resolution that would provide the authority to myself and to our CEO, Harry, to execute a loan agreement and a security agreement and a note to secure a loan with the California Health Facilities Financing Authority. What's happening at the moment is the state is transitioning us from the PRIME program to the QIP program. And during this transition, because of alignment with the state's year and coming up with the program criteria, It has created basically a two-year delay, slightly longer than that, in funding that we would get from the QIP program. So we continue to have staff that are working on the QIP program. So we incur costs during this time period that we are not reimbursed for until probably about starting mid-2023. We're not losing out on reimbursement, we're just delayed in the reimbursement from this program. The reimbursement from this program is very close to being the same as what we got under the Prime program. Again, this is just a delay than anything else. In working with the District Hospital Leadership Forum, many district hospitals could not survive and continue working on this program without that reimbursement. They couldn't cover salaries and wages and benefits of the folks that were working on this program. And so the District Hospital Leadership Forum worked with the California Health Facilities Financing Authority to create basically what in essence is this bridge loan program. There is about $40 million that was made available to districts where they could apply for a loan to help bridge the gap of covering costs until reimbursement kicked back in. Many hospitals, like I said, would not survive if they didn't have this loan. And there are some hospitals like us who don't necessarily need it because of our financial strength, but without participation, other hospitals may not have funding available. So it was important to show a united front by district hospitals to support those that were in desperate need of the funds versus an organization like us who could benefit from the funds but didn't necessarily have to get the loan. So the District Hospital Leadership Forum did work on an algorithm for the amounts allocated to each of the district hospitals. Tahoe Forest is on the low end of the request with a loan of $281,584. Not all district hospitals chose to participate. There's a handful that just flat out opted not to do this, but a majority were in it. There is the possibility of a second round of funding for those hospitals that continue to need it. We would not participate in the second round. This is the one and only round that we are would be participating in. It is a 2-year loan with 0 interest during that 2-year period. It is to be repaid in its entirety at the end of that 24-month period. There is a 1% fee that is non-refundable to participate in the program, and this is to cover administrative costs of administering the loan, the documents, etc. So that 1% is not interest. If we do not need to utilize the funds with our investments, we could easily earn more than 1% on this money over the next 2 years. So we aren't out any money if we end up not utilizing these funds. So that is what's before you today. You have the resolution, which in my copy came through kind of funny. I don't know if in your board packet you have a bunch of squares in your resolution, but mine is. And then you also have the actual loan and security agreement and other documents. And then I did include a little blurb that's some background information on why Prime is transitioning to QIP. So I will leave it there and ask if there's any questions.
Our board looks stunned.
Well, I could say that your finance committee, Mary Brown and I reviewed this in detail at our meeting last Tuesday. And I think the operative consideration here is that while we don't need the funds, it does help the other hospitals who would not otherwise get them if we didn't participate. And as Crystal said, we can, with our new Chandler Asset Management Company getting us a better rate of return, we can easily earn above that 1% cost and then get the money back at some later date.
And that later date would be in 2 years, Crystal?
So, yes, right now with the rates that Chandler is showing us, it's about a 0.70% interest that we would be earning. If we earn just 0.5% a year, we would be covering our fee. So just the interest alone on these dollars, if we don't expend them, will cover the 1% fee. And
This
just
is,
one more thing. Oh, sorry, Mr. Barnett, go ahead.
with regard to the repayment, is that from the 2-year deferred source?
I'm not quite sure I understand your question. The
Well,
money
this
will
is a
be
bridge
provided.
loan for 2 years because there's funds that we expect to receive in 2 years. So when those funds come in, is that what we use to pay the bridge loan?
So by the time this program kicks into gear, it'll be about the 2-year mark from when reimbursement will start happening. So these funds are to help hospitals get through those next 2 years until the program, the QIP program, starts sending the funding out to those hospitals that have met their quality metrics. And at that time, we will be required to repay it at that 2-year mark.
Okay, that answers my question. Thank you.
Sure. And the last comment I would like to make is, if for those of you that have been on the board for a while, the District Hospital Leadership Forum was created several years ago. Bob Schapper and myself were some of the founding members of that forum. It was to bring district hospitals together to have an all for one and one for all kind of mentality to support district hospitals in getting the appropriate reimbursement that we should be entitled to as public entities. So this falls right in line with the nature of the forum to support other district hospitals who are in need.
Okay. Any other comments from the board? Okay, seeing
No.
none.
I would move approval of the resolution.
Let me see if there is anybody in the office, and then we're going to come back to you, Mary. Anybody in the audience have any questions or comments regarding this bridge loan? Okay, hearing none, then I will go back to you, Mary.
And I'll second.
Okay, so it's been moved by Director Brown and seconded by, I'm sorry, I didn't see who seconded it.
Dale.
Dale, Director Shamlin, to approve resolution 2021-08 authorizing execution and delivery of a loan and security agreement, promissory note, and certain actions in connection therewithin for the California Health Facility Financing Authority non-designated public health bridge loan program.
That's a mouthful.
That sure was. So now can we have a roll call vote?
Director Barnett,
Yes.
Director McGeary,
Yes.
Director Shamblin,
Yes.
Director Brown,
Yes.
Director Wong.
Yes. So you have that, Crystal, to go ahead and apply for those and get the signatures you need to send on.
Thank you.
Okay. Our next item for board action is a President and CEO employment agreement. And we have Mary Brown, who is the chairman of the Executive Compensation Committee, who's going to present to us.
Right. Thank you, Alice. Yes, I'm before you in that capacity. And I want you to know that the Executive Compensation Committee met in December to review and revise the CEO compensation package. And that revision is as follows. The new base salary will be $657,494 per year. And the incentive compensation will be awarded to a limit of 30% of base salary if all targets are met during the year. There will be a signing bonus of $30,000 and an auto allowance of $900 a month. And I would move approval of that change to the employment agreement.
And just as a point of clarification, it is a new employment agreement that's before the board with a term beginning January 1st, 2022 through December 31st, 2025, which is a 4-year term.
And Mary, I'm sorry, did you mention about the sign-in bonus?
Yes.
Yes.
Okay. So any questions from our board has discussed it in closed session. And is there anything from our audience regarding the contract? Okay. So there's no discussion. Then I'll move it to Director Brown to give us a motion.
I would move approval of the new employment agreement.
I'll second. Michael?
Okay, so it's moved by Director Brown, seconded by Director McGarry, that we approve the new employment agreement. And a roll call vote.
Director Barnett,
Yes.
Director McGarry,
Yes.
Director Shamblin,
Yes.
Director Brown,
Yes.
Director Wong.
Yes. So the agreement has been approved as presented. So Harry, there's your new contract.
Thank you. I just want to say a big thank you to the board for your independent, thoughtful work. We do have a great team here, and my focus has been really on my team and how I feel like that they should be treated. And I thank you for your thoughtfulness.
And then we'll move on to item 18, and this is the board officer election. Every December, we elect new officers to the board. We have a chair, a vice chair, a treasurer, and a secretary. And by bylaws, but that's why we're doing it in December. So can I open it up for discussion amongst the board?
Alice?
Yes.
Dale here. You know, given the continuing disruption due to COVID, resulting in our inability to meet face to face this last year, and we've had to adjust. And I think we've done an admirable job in doing that adjustment. And we also had to successfully replace a board member during the last year who is just now coming up to speed. So under those circumstances, I would propose that we reelect all officers to serve another year in their current positions.
Okay. Is there any discussion on that proposal? Those of you that are officers, which is everybody but our newest board member.
Well, as the newest board member, it seems like a good idea to me.
I think what we're hearing is a nomination
Yeah.
from Director Chamblin of all the existing officers to remain. So that would be the item on the floor. And just as a point of order, for the chair to be reelected to successive terms, our bylaws require a unanimous vote as to that one office.
Okay, so shall we do that separately from the rest of the board then, David?
I mean, yeah, technically we should probably take them one at a time. But maybe at least do the chair separately so that we've got a record of that separately.
Okay. All right. So could I, Dale, do you want to make a?
Yeah, so I will make a motion to reelect Alice Wong to the chair position for the coming year.
Could I have a second to that motion?
I would second that.
Okay, so it's moved by Director Shamblin, seconded by Director Brown, that Alice Wong remain as chair of the board. So that, could I have a roll call vote, Martina?
Director Barnett,
Yes.
Director McGarry,
Yes.
Dr. Shamblin,
Yes.
Dr. Brown,
Yes.
Dr. Wong.
And I guess if it has to be unanimous, I'm going to have to say yes.
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 So thank you to our directors for the confidence and allowing me to continue on as chair. Now,
Thank
there has
Thank
been
you. Yeah.
Thank you for your willingness to do it.
Yes.
we'll see how the year goes, okay? But now it's time, there has been a proposal, and maybe someone could make a motion that we continue the officers as they are now seated in their position. Correct, David?
Yeah, you might, let's reiterate who those individuals are.
Okay. So we have Mary Brown as our vice chair, Dale Shamlin as our treasurer, and Michael McGarry as our secretary. So the proposal would be to keep these officers in their positions.
I'll second that motion.
Can I make a motion as the chair?
Why not?
Yeah, technically it's a nomination, and
Oh.
nominations technically don't even need seconds. They just need
Oh.
the nominee to accept the nomination.
And then that's it. If everybody says yes, we don't do a
And
roll call vote.
then you do the vote.
Oh, okay. So is there anybody who is not willing to accept their position?
Silence is consent.
Okay, and then we should do a roll call vote now.
Yes.
Director Barnett,
Yes.
Director McGeary,
Yes.
Dr. Shamblin,
Yes.
Dr. Brown,
Yes.
and Dr. Wong.
Yes. So welcome to our board and our officers. Our next item is any board committee reports.
Yes, as I mentioned, the finance committee did meet, and we got a lengthy report from Chandler Asset Management. If you'll recall, we recently got a firm to invest our additional funds at rates that will exceed what we were getting from LAIF. And the plan is for the finance committee to get a quarterly report on our successful investment of these funds.
Okay. So our first report will be when then, if it's quarterly reports?
Would be March then. Would that be right, Mary? I would say.
I think it was March, yeah.
Okay. Just so that we have it on the calendar, that'll be on the agenda.
Yeah.
And
it may be part of the finance committee report, so.
Right. Well, Alice, we'll probably do an annual update for the entire board of directors, probably closer to year end, and kind of have an annual cycle of an update to the entire board of directors, but the intent is quarterly with finance committee.
oh, okay. Thank you for that clarification. Any other reports from our board?
Yeah, maybe 1.5. The foundation, in lieu of a meeting last month, did have a holiday get together, which was fantastic. So everyone got together in person, but no matters discussed, purely social. And then the board quality committee did meet. A number of updates on the PFAC, Beta Heart, and then a detailed update or a quarterly update on governance of quality assessment tool. The spotlight for this quarter, we agreed every quarter we would really do a deep dive into one of those items. And the spotlight this quarter was on behavioral health, and fantastic update on progress being made there to really make a tremendous impact on the community on behavioral health. Those are the highlight of the meeting for me. And then we walked through the care compare quality metrics. Janet walked through in detail. Really, it gave a much better understanding of why our score dropped to a 2-star. and some of the efforts being done to address that. I think the most notable point there, though, is that the metrics are delayed, right? So we're looking at data that's a couple years old, so we can't expect sort of an instantaneous, let's fix this next quarter. It's going to take a while to get that 2-star rating up.
Okay.
One quick addition to Michael's report. Michael, I met with Carly Epstein and Judy Newland. One of their concerns was that your board really doesn't have much representation from the north shore of Lake Tahoe. It's more truckee centric. And so we together came up with a list of names of individuals who might be interested in joining the foundation board, might be interested in donating, et cetera, et cetera, et cetera. So anyway, we had that conversation and hopefully something will come out of that.
That's fantastic. Thank you.
Yep.
Any other comments? Then I'd like to make a comment. If Karen Buffon will turn on her mic. This is her last meeting. She's retiring as of this year. And I just wanted to tell her, if she's really there, how much we have appreciated all the things she's done for the district. Everything that she's done with population health, with the wellness neighborhood, with the huddles that have made such a difference in the care of our patients in real time. So Karen, thank you again, and we wish you the best as you go into retirement. We love you.
Thank you.
We will miss you.
Yeah.
Thank you so much. I'd like to thank all of you for all the support that you've given to me, all of my people, all of the programs. It's been an amazing time at Tahoe Forest. We've accomplished a lot, and I am super excited to head into retirement. So thank you. Thank you very much.
Oh, enjoy for sure.
Best wishes, Karen.
Yes.
Thank you.
And then on behalf of the board of directors, we want to wish all of you a very happy and safe holiday season and a joyful new year. And I've waited all year to say this. Merry Christmas to all, and to all a good night. So the meeting is adjourned.